Hey, our next guest here is a board-certified diplomat of neurology through ACNB. He founded the Arizona Chiropractic Neurology Center. He's been practicing since 1997. Over the past 15 years, he's become one of the most in-demand international speakers on the subject of functional neurology. He travels all over planet Earth talking about things like nutrition, functional neurology, and how these things go together. He founded BTB Health Systems and has been hired as Chief Client Officer for Applied Functional Neurology. He has published research all over that you've probably read in the subjects of neurodegeneration and traumatic brain injuries. So basically, this guy is the foremost leader. I had the privilege of talking to him backstage about what's going on inside your brain, my brain, and every brain out there. So, ladies and gentlemen, do me a favor. How about a warm welcome for Dr. Trevor Berry?
About every 4 seconds, somebody worldwide is hearing a dementia diagnosis. About every minute in this country, somebody's hearing the diagnosis of Alzheimer's like dementia. Statistically speaking, a lot of us in this room right now are right in the crosshairs of succumbing to a neurodegenerative condition like Alzheimer's. And what we were talking about backstage is it doesn't just affect the patient, it affects you as the caregiver and the family. That's the most understated thing about these neurodegenerative conditions. It's going to take a toll on everyone in this room in some way, shape, or form. The trajectories keep skyrocketing for these conditions. When I line up 10 of my Alzheimer's patients, I will have 10 different treatment strategies. Okay? Maybe it's a dysglycemia pattern, Western lifestyle. Maybe it's a autoimmune-based triggering event. Maybe it's a leaky barrier system pathogen type of scenario. Whatever the condition and case I'm seeing in my office, not just dementias, but Parkinson's, movement disorders, post-concussion syndrome, neurodevelopmental things like autism and whatnot, there is one common denominator of treatment. Every single one of my patients gets transcranial laser therapy in my office. We get this light on their heads. I dare say it is the most neuroprotective thing you can do for your brains. When you look at just one monotherapy that checks off the most boxes that we need to protect and repair our brains, it's low-level laser therapy. And that's not dismissing all the great information we're going to get this weekend, working with stem cells and regenerative medicine and nutrition products and things like that. But when you look at all the major boxes that need to be checked, transcranial low-level laser therapy has the capacity to do that. A lot of you that have seen me speak in here know why I'm so passionate about this topic. I was already in the field of integrative neurology in practice, but my ex-wife and I have 2 beautiful young daughters. That's Ava on my left. She's doing her pre-med at University of Arizona in Tucson, studying neuropsych, but she's taking a very integrative approach. I have her reading gut zoomer 3.0s and micronutrient profiles with gene SNPs and like, what does a COMT patient look like when they get methylation, things like that. We even have her looking at psilocybin and MDMA and things like that, the plant-based medicines, really taking a truly integrative approach. My youngest, Sienna, on my right, she's about to turn 18. Thankfully, I don't have to save up for college for her, but I do need to save up for bail money. So she is definitely my daughter. My ex has such a severe genetic predilection for Alzheimer's. We're talking the ApoE4s, the TREM2s, PCM, you name it, every gene SNP, her family has it. They have not had a family member on her maternal side get past the age of 60 without full-blown late-stage Alzheimer's. When their grandmother was still alive, the last time I took my daughters to go see her up in Vancouver, at best, she was catatonic, just staring at a wall. But she was typically one of those dementia patients that was very belligerent. She would just eviscerate you. And the last time my kids saw her alive, she just eviscerated the entire family. It was traumatic for me, and I deal with this stuff for a living. You can imagine what a 5 and 8-year-old would be. That's their last vision of their grandmother. When we got back to our in-laws' house where we were staying at the time, I could hear them both crying in the bedroom, and I went in there to console them and try to explain to them what was going on and that kind of thing, just to help them understand a little bit. I'll never forget, they both looked up at me and said, "Daddy, this isn't going to happen to us, is it?" I said, not on my watch. I said, I will devote every ounce of energy, everything I do clinically, research, in practice, to find ways to protect you two. So this is my why. Vibrant said when we put their speaker packages together, can you keep your slides really clean and not too much verbiage? So here you go. But I did this by design, because what I did with this is a punch list, if you will, bullet point list of some of the highlights. When you do PubMed review, lit review on PubMed or Google Scholar, whatever, there's over 16,000 papers on low-level laser now. And so what I wanted to do was kind of just go over some of the highlights of why this is such an integral part of our brain-based rehab. Number one, what I would consider, and many would consider, the holy grail of brain rehab is neurogenesis. Your brain neurons are not my talk. They don't turn over like a liver, gut lining, things like that. So promoting neurogenesis can be accomplished by shining low-level laser on the brain. In particular, they've shown increased gray matter in areas like the hippocampus. Well, that's your primary origin of Alzheimer's-like dementia. So one of the things I will do every lunch, and I hope you guys do it as well too on a regular basis, is they've also shown meditation has been shown to promote gray matter in the hippocampus, your memory switchboard. So every lunch, I will sit under my lasers and meditate. I will do 5 minutes of meditation of gratitude. You know, like, what am I happy about? Anything you can be happy about can alter your default mode network. Like, to me, this morning I was meditating, I got to eat a whole pound of bacon. You know, so I was like absolutely in a happy place with that. So, and then I go into 5 minutes of pure meditation, which is just clearing your mind of everything. Very powerful way to promote gray matter in the hippocampus. But all of your growth factors, like nerve growth factors, BDNF, brain-derived neurotrophic factor, has been shown to be upregulated with transcranial low-level laser therapy. So we like to stack our modalities. A big clinical take-home is that when you're doing things to activate these trophic factors, move the body. You know, of all the people we sent to the Olympics, for example, one of the things I would do is when I'm working with the reaction time, eye-hand coordination, hand speed, things like that, we're lasering areas like the prefrontal cortex and cerebellum while they do those kind of movement patterns to stimulate and really create that synaptogenesis or neuroplasticity of the new pathway connectivity, insulin-like growth factor, vascular endothelial growth factor, you know, new blood vessel formations, all with low-level laser therapy. I'm a huge fan of regenerative medicine. And lasers by themselves will promote stem cell production. But what I love about a lot of you that are doing regenerative medicine in here, stack lasers, because when you laser the target tissue, say you're using peptides or exosomes or stem cell, you know, pluripotent stem cells, when you laser, whatever your target tissue is with the laser, it will draw the stem cells to the target tissue. And it promotes differentiation of said target tissue. So maybe it's a chondrocyte, you're doing a knee rehab and you want chondrocyte proliferation on the brain. It will promote neuroglial differentiation. It's been shown to protect and repair the barrier systems. So by directly lasering the brain, lasering the gut, and even indirectly, we'll get into vagal nerve stimulation, can protect your blood-brain barrier and repair your blood-brain barrier, which is going to be a big underpinning for this weekend. Reduce brain inflammation and promote glial resolution. If you are a genetic predilection for Alzheimer's, it doesn't necessarily have to express itself, but the number one thing that's going to push you off that cliff is chronic brain inflammation. Okay? And whether it's a dysglycemia pattern, the LPS, I'm really looking forward to Dr. O'Brien's talk about those kind of things, because that brain inflammation is what's going to cause that epigenetic tripwire to be triggered. Now, I'm a fan of nutrients, the glutathiones, NAC, the BCM turmerics, the resveratrol stacking, all these things that we can use for nutrition. But this device right here has been shown in research to mitigate all pathways of inflammation, interleukin-6, interleukin-1B, TNF-alpha, nuclear fat, all the major inflammatory cascades can be turned down with low-level laser, not just to the brain, but obviously other areas of the body. So this is one of our best anti-inflammatory tools. If you buy into the theory that amyloid plaque is the smoking gun of Alzheimer's, which obviously that's very debatable as to what all the major underpinnings, you know, there's relevance. I'm not dismissing amyloid, but amyloid reversal and protection against amyloid buildup has been demonstrated in studies with laser. So has tau. So your protein misfolds, you know, you're looking at, you know, for a common example would be something like glutamate excitotoxicity. Excess glutamate binding, excess calcium in the cell, you start kicking off faulty proteins. You get these misfolded proteins. The neurons can't talk to each other. They wither away and die. That neurofibrillary tangle, okay? That's why we don't like things like diet soda. It's no different than getting punched in the head, basically. So it's like, what can you do to protect your brain against glutamate excitotoxicity and tau hyperphosphorylation? Pre-treat with laser, okay? I want every single one of you in this room, if you're not doing it already, is take the magnesium that is best for protecting the brain, crossing the blood-brain barrier, and that's called magtine, or magnesium L-threonate. It is one of the most important micronutrients you can use because one of its mechanisms is that it's the protective plug in the NMDA receptor so that you don't get that excess calcium influx, if you will, and these faulty proteins or, free radical damage and the cells going poof, apoptosis. So please, all of you take magnesium L-threonate starting today if you're not already. How about all of your immune regulation stuff, your proper immune responses? So we look at, vitamin Ds and As and these things for, interleukin 4 and 10 and TGF-beta and all these types of immunoresolution things. Well, lasers have been shown to promote that as well too, okay? And there is evidence that lasers will directly take out pathogens, even potentially viral capsid, like mechanically disrupt a virus, okay? How many of you in here have herpes? I'm kidding, don't raise your I'm kidding, don't raise your hands. But that's one of the things that we're finding in the brains of Alzheimer's patients, herpes simplex 1, herpes simplex 2. But it's not just these pathogens like the viruses. How about just simple gingivitis stuff, your dental biofilms? We're seeing Prevotella and strep mutans and porphyromonas, all these things in the brain's tripwiring Alzheimer's responses. That's why we do things like coconut oil pulling, laser around the teeth and things like that, proper dental hygiene. These lasers have been shown to actually take out all those dental pathogens. This device that I put on me right here, the red violet, this is 635 and 405, you can kind of see it reflecting here. That's been shown to take out MRSA. That's how powerful of an antimicrobial this tool is. So we use this a lot in that setting. How about all of your antioxidant systems? Okay, you've got your glutathiones, your catalase, the laser's been doing that. That's why we laser the liver, the brain, all those kind of things. We did pilot studies lasering the vagus nerve, showing improvement in heart rate variability. Now, I'm a huge fan of tragus clips and Hulist and, the home things, gargling, humming, all these kind of things you can do for the vagus nerve and the brain-gut axis. But we did independent studies with heart rate variability showing that lasering the vagus nerve would actually promote vagal tone and heart rate variability. We even saw that the research evidence shows that the vagus nerve loves a 10 hertz frequency. So we can even program our lasers to be that specific for activating the vagus nerve. And one main clinical take-home point I'm going to say is this. I'm the biggest advocate of nutrition and diet and supplementation, all these. If your lower brainstem and your brain in general is not working well, good luck having a healthy gut. It's really hard to nutrition our way out of some of these cases when there's that underpinning of the functional neurological issue. So doing things like vagal nerve stimulation to promote brain-gut axis, massaging the gut. There's over 7 times as much neurological information that goes from the gut to the brainstem. Make part of your functional medicine practice, do things, because any kind of practitioner can do vagal nerve stimulation, whether it's lasering, massage the gut, doing the other devices you can get, doing home-based stuff. It should be an integral part of your practice for barrier systems, for blood flow, for peristalsis, for all that stuff. That's all neurologically mediated. So definitely consider that in your clinical practice. How about the energy failure model of neurodegeneration amongst other conditions? That is a major player, the mitochondrial stuff. Like some of the major medication side effects I think metformin right now is the 3rd most prescribed drug in America. Well, one of the side effects of metformin is that it wipes out mitochondrial electron transport complex 1, the NAD complex. So FAD, you got the ubiquinol, then the cytochrome C oxidase. Well, you can go a step further, and it turns out that the complexes 1 and 2 actually have an affinity for violet laser, a 405 nanometer. So you can protect and repair the mitochondrial complexes 1 and 2. The complex 3 has an affinity for green. Complex 4 has an affinity for red. So one of the things that we're doing with all of our patients is we're actually not just using red light therapy anymore. We are using violet and we are using green as well. And when you can stack all 3, red was good. That's where the preponderance of research is. But if you can stack multiple colors into your therapeutic strategies, you'll have even better outcomes. And the lasers have been shown to promote mitochondrial biogenesis. So you'll actually get not just new neuron formation, but new mitochondrial formation using light therapies. How about preventing neuronal death and spreading effects? So God forbid you get a TBI, you have a stroke situation, something along those lines that causes a focal nidus, causing neurons to go poof, apoptosis situation. It's going to start wiping out adjacent neurons through glutamate, through proteolytic enzymes, things like that. If you have pre-treated your brain with low-level laser therapy, you actually can decrease the size of the nidus. They've even shown another ischemic tissue activity like myocardial infarctions and things like that. So we get lasers on the brains, not just after the fact, but again, as a prophylactic mechanism to try and mitigate these things if they happen. Pain, you look at the pain mechanisms, that's directly linked to brain activity. So lots of I was principal investigator of a couple of chronic pain studies and things like that, looking at how lasers can tamp down pain in all areas, low back, neck, shoulder, those kind of things, help patients sleep better, which is a big thing for neurodegeneration and whatnot. But we're even using lasers and stacking it with, say, we're doing chronic pain with cognitive behavioral therapies, doing talk therapies and things like that, lasering the prefrontal cortex for things like those higher levels of pain inhibition that we can expand on later. HP axis regulation, okay? You can have direct gonadal output increase, spermatozoa, oocyte production, things like that by lasering the tissue, okay? Adrenal function, thyroid, a lot of you, we're all dealing with Hashimoto's and things like that. Lasers have been shown to decrease TPO and TGB antibodies while we come in behind and get to the root cause of it. The violet laser has been shown to decrease non-cancerous thyroid nodules and whatnot. So again, a lot of you in that realm of working with the HP stuff, it could be a very integral part of your practice as well. Last, the main impetus behind this weekend is protect and repair against DNA and RNA damage and telomere shortening, and you're looking at the NRF2 stuff, SIRT1, things like that. Lasers have been shown to protect against the aging process at a cellular level. So I ask this to all my audience: could you imagine if a medication could do all that? Every single one of you would be taking that medication, okay? Supplements, think of anything that we do in practice that checks off those boxes, okay? So what's the catch, right? There has to be a catch to that. There's too good to be true kind of thing. Well, we are looking at the idea that there's a sweet spot for laser, okay? There's a dose response. So I just put a couple papers in just showing, here's a systematic review showing that together photobiomodulation can be a useful tool in treating Alzheimer's disease. How about in our genomic stability? Studies have shown that laser-induced effects on genome and telomere shortening or stabilization suggest that exposure to lasers modulates DNA repair mechanisms, telomere maintenance, and genomic stabilization. So, some of the major things that we're talking about this weekend, there's plenty of evidence. What I did when you talk about what's the catch is I've spent the last probably 18 years reading thousands of published papers on low-level laser therapy. And along the way, I was looking, what are your ideal dose, treatment, wavelength, all the treatment parameters? What's getting the best outcomes? And what ticks me off is I think of the thousands of hours I took reading these papers. On the holidays this year, when I was putting together my new slide deck, I took ChatGPT, OpenAI, and I punched in, what's the best dose of low-level laser therapy to the brain? And within 4 seconds, it kicked out exactly what it took me over a decade to figure out. So 0.5 to 10 joules per centimeter squared is the sweet spot, okay? If you start exceeding 15, I know that sounds Greek right now, but if you start exceeding 15 joules per centimeter squared, you're getting into the no-fly zone. There's like a Goldilocks effect, especially on brain, but you see this in pathogen studies, you see this in cancer studies, you see this in all kinds of different studies. That 10 joules per centimeter squared is your sweet spot that you do not want to exceed, okay? Another one of my really clean, tidy slides. So low-level laser, you want to stay in the visible sweet spot. If it's safe for the retina, it's going to be safe for the human brain. So you will see the visible light element with regards to being in the sweet spot of laser. So most of the preponderance of laser research is right around that red, about 635 to about 810, okay? That is fine. You're good in that area. You want typically below about 810 nanometers for wavelength. That's what makes it red to the human retina. On the other end of the spectrum is violet, if you will, on the rainbow. And so we all know that UV light has very good antimicrobial effects. But if you lay out in the sun too long, you get a sunburn, it can cause free radical damage, cancers, things like that. If you're in the visible spectrum, like this violet light at 405, you actually get the benefits of UV light without the free radical damaging effects, things like that. The technical thing is if you exceed 10 electron volts, you're going to start throwing valence electrons like in X-rays and CT scans and things like that. But violet laser at low level actually only hits 3.06, so you don't have to worry about the free radical damage. But the big question a lot of people have is the higher powered stuff. Because the rhetoric that you hear in the light industry, well, if low-level laser's good, then more power must be better. And that is not true, folks. Okay? Think of it in practical terms. If I start getting up, what's the next one past red? That's infrared. Okay? Those are longer wavelengths. Those they're not for the photochemical effect like on the electron transport chain. What do longer wavelengths do? Well, what's next after infrared? Microwave. Okay? Your longer wavelengths are vibrating water molecules to heat tissue, okay? I am not going to stick a high-powered laser on somebody's head, just like I'm not going to stick your head in a microwave and turn it on, okay? I even get a little bit weary about some of these infrared saunas and things like that. I'm a big proponent of it, working with our mold patients and things like that, drawing and binding. I had dinner last night with Drew and Ed from Cellcore, using infrared to draw and bind these, biotoxin binders and things like that. So I'm a big fan of it, but if I'm doing infrared stuff, I'm typically doing the saunas that are from the neck down. I would rather you err to that, okay? So these longer wavelengths, they do not excite the electrons into the outer orbits to create all the magic that you need in a true photochemical effect. All class 3B or higher lasers get 510 FDA clearance as a medical heat lamp. Okay, that's how they come to market. It's not as a laser, it's as a heat lamp. Okay, again, if you want to spend that much for a hot pack, that's on you. But I am looking at a photochemical. That's why the low level thing is such an important thing. Next thing a lot of you ask me about is red light therapy. Okay, big difference between LED and true laser. True laser, all those photons, billions of photons per millisecond, are all collimated, monochromatic, parallel, coherent, all working in the same direction at the same time. LED is scattered photons. Okay, it's like taking a red light bulb and shining it next to somebody. Are they going to get some photon exposure? Yes, they will. But in any of the brain-based studies, we're not getting good results. In our autism study, we got 0 results with LED. Okay, the pain studies, there were certain things with LED. I put up there one example. This was on the chronic pain study. Just to give you context, when we do our FDA clearances, these are level 1 clearances. They're double-blind, randomized, placebo-controlled, multi-site studies. You know what our sham is? LED. That's our placebo that we use against true laser. So you can see in this chronic pain study, that top line right there, that is LED. And after we stopped the study, all the LED patients went back to baseline. The true laser patients continue to improve, not just 16 weeks after and whatnot, but a year later. So there's a cumulative effect. So true laser versus LED is not in the same stratosphere. Now, I will say this as a brain guy, if you're going to err to the side of which end of the spectrum, the higher powered class 4 on the brain or LED, I'm going to err to LED. At least with LED, the worst that's going to happen is nothing. I'm not saying it doesn't have any physiological effect, but just compared to true laser, it's not even in the same wheelhouse. So I don't mind these LED caps and things like that, but it's more likely to be more for like hair growth than it is a brain-based rehab situation. So what I decided to do for a case study is just talk about, I think, a case that, because the one test that Vibrant, of their great testing platform, this test gives doctors the biggest fits that I found when I'm doing clinical consults and patient consults and things like that. This was a 61-year-old female professional cello player. She developed rigidity, stiffness, and focal dystonia of her right upper extremity. Her initial symptoms included moderate constipation and loss of smell, which she initially thought was COVID-based, was the loss of smell. But man, loss of smell with neurodegeneration, if you're losing smell, that is an ominous warning sign for brain-based conditions. You guys may have did you see the plastic study about 2 weeks ago? That of all the areas of the brain that the microplastics were hitting, it was actually the loss of smell that was the worst, even with the microplastic thing. Okay? But if you start to see constipation, rigidity, like movement type stuff, and loss of smell, that is a early warning sign of your Parkinsonian types of presentation. And she was using magnesium laxative. She had severe balance problems, and was also having a hard time following directions, recalling names, and just basic instructions. You would say something to her, she couldn't follow, like how to get to the store, things like that. She describes her body as not cooperating. She feels like her brain can give commands, but the signals aren't getting to the rest of the body. Now, here's the thing. She was as a professional cello player, she had to quit the symphony and playing cello altogether. And even her fun things she liked to do, like pickleball. That's such a huge thing in Arizona. She was starting to have difficulty with just basic daily activities, getting out of bed, putting clothes on, and even eating. Her medical management assessed her with Parkinson's-like dysfunction, and her unified Parkinson's rating was 41, which is pretty significant. They prescribed a treatment trial of levodopa-carbidopa, but it made her constipation so severe, and she was so fatigued due to the worsening of sleep quality, and she was really lightheaded. She didn't feel like it helped her muscle symptoms much, and noted the side effects were not worth the minimal benefits she was getting, if any. During her bedside exam, she had all these, the dyspraxias, the cogwheel rigidity, the freezing, the hesitations, or, the shuffle gait, that bradykinesia stuff, her up and go test was all the classic Parkinson's signs. But she also had a wide-based gait. She was more like this with the shuffle. That's not typical. That's more typical cerebellar-based stuff, like an ataxia. If you guys want to see what that looks like, go to the cocktail party last night. All the vibrant reps. But she had terminal dysmetria. I'm kidding. They're all cleaner than I am. Terminal dysmetria, things like that. So there was more going on with this case, right? Yeah, she showed those Parkinson's signs, but there was a lot more going on with this case. So what I did was I ordered a NeuroZoomer Plus to get a better look at the big picture. And if you look here, sure enough, she did have the anti-dopamine 1 receptor. So that's, classic D1 Parkinson's pathway. That's your GO pathway. A lot of you that may work with more of the hyperkinetic hyperactivity disorders like PANS and PANDAS and autoimmune encephalitis, that's more typical of your D2. So everything in your nervous system has a gas and a brake, okay? Just like your basal ganglia, your cerebellum, your autonomic nervous system, things like that. So your gas system of the basal ganglia is your dopamine GO system. Okay, that's your D1 pathway. The D2 pathway often gets hit with strep. That's your most common autoimmune trigger or molecular mimicry trigger. So if a kid has strep and they start, if it's improperly treated, that may tripwire a whole, if they start acting up, losing inhibition, just, if anyone works with PANS and PANDAS, they know exactly what I'm talking about. But you'll see here the anticerebellar. So there it is. There's some of that ataxia and dysmetria, all those cerebellar types of signs, the dysdiadochokinesia. And so then we start looking at, well, what's your major molecular mimicry? I know this is low-hanging fruit for this group, but gliadin, gluten-free. She wasn't gluten-free yet. So obviously getting her off gluten was going to be a big part of her treatment strategy. But some other things that caught my attention on this test, you'll notice they're the Epstein-Barr, right? And going up to the demyelinating agents, she's starting to show autoimmunity to demyelinating agents. On those findings, we are seeing a 32-fold correlation of Epstein-Barr to MS. 32-fold correlation of Epstein-Barr. To give you context on that, we all know smoking causes lung cancer. That's a 25-fold correlation. So Epstein-Barr and MS, you are a ticking time bomb. So one of the things I love about these tests is just because you have certain markers like that, does that mean it's actually expressed itself yet? No, not necessarily. But if you, as the patient, know you're right in the crosshairs of something like that, you can be more proactive. Maybe you're going out, starting on the walls protocol and those kind of things preventatively before it actually manifests as end-stage disease process. Okay? So this test is very robust. It's very complex. What was that? Was that a PANS patient? Yeah. This complex is very robust and complex. So a lot of you that call me for, doing consults of this test say, Doc, where do I start with this? I'm not in neurology. What do I do with this test? Okay, I'm going to ask you this. Do you think all of you can hit the start button Okay, everyone point to your prefrontal cortex. Put the laser on the prefrontal cortex. Boom, now I bestow upon you honorary diplomats of neurology. Because that's all I'm asking. I can safely say with a proper safe laser like this one is, whatever you find on that test, this can be part of your treatment strategy. And when you think about all of the boxes that this checks off, like we talked about earlier, this can be an integral part of every treatment strategy with your NeuroZoomer Plus in some way, shape, or form, okay? So then we started to expand, and this gave us more clinical guidance on our treatment parameters, and so we got her going on the dietary changes and things like that. What we did initially is we utilized just a 6-visit initial treatment trial. And one of the things I'll introduce at this point is the diodes in this laser are only 7.5 milliwatts. Okay, some of these high-powered lasers are like 60 watts. This is milliwatts. And then the wavelengths give us the color, so hence the red-violet, which is really important for Parkinsonian type conditions. So we also use this scanning laser that's at 17.5 milliwatt diode. And all we did was just a 6-visit treatment trial, just to see how she did with it. And when we did it, we did more prefrontal and cerebellum. Now, what hand did I say was being an issue with her? It was mostly her right, with the dystonias and things like that. So that's more of her left. So you can even get a little bit more into that arena of, I'm going to bias my lasers and treatment to the left prefrontal cortex, which is heavily driven by the right cerebellum. Okay, so I even bias my lasers a little bit, like here and here. And by the way, if some of you are worried as I flash this around, you're like ducking, like, oh my God, okay, this freaks people out. That's how safe this laser is. We're doing macular repair studies, things like that. Don't do this at home, kids. Don't do this with any other light device. I'm only saying this to illustrate something, that how safe a true low-level laser is, okay? So don't worry if you happen to see it go by you, kind of thing. So if anything, get in front of it. Get your head under there, right? But we would do that to bias that, and left frontal for that right hand activity. She did so well with her gait and positional change and bowel movements that she came in, and we do a 12-visit treatment trial as our initial package, if you will. So then we started stacking her modalities. So it wasn't just laser at this point. So here's some of the things that we did with her. We did fast eye movements. This is a big thing with Parkinsonian stuff and frontal lobe type things. Those are your saccades are generated by the frontal lobe. So if you see me doing this with a patient where they're touching really quick, that's a really good frontal type of dopamine generator. What kind of gyms do they have for Parkinson's patients? Boxing gyms, right? Does that make sense? You're like, what is it, like Muhammad Ali getting whacked in the head? That's silly. No, it's the dopamine get up and go type of thing. You want to do those kind of therapies with a Parkinsonian patient. Okay, so we did that. We did linear extension with metronome. So timing stuff is really good for brain development, neurodegenerative disorders, neurodevelopmental disorders, things like that. And if they can't do it actively, you do it passively for them. So sometimes, whether it's a kid, a late stage dementia, whatever the case may be, a stroke, you may have to be doing those things for them. Also, do isometrics, okay? That should be an integral part of your rehab strategy, not just spurt movements, but holding, planks, things like that. Everyone hold out your thumb. Look at a target on your thumb, and I want you to do a small no-no movement while you keep your eyes on that target. That right there, for less than 10 seconds times about 3, is one of the most powerful midline pathways you can fire. Okay, it's called your fastest reflex of the human body is called the vestibular ocular reflex. Okay, that's actually what drives your postural muscles. So your curvature, if you're suffering from low back pain or neck pain right now, your blown out discs, things like that, that exercise right there is more powerful than taking like a 45-pound plate and putting it on your head, kind of thing. But then what I'll do, like if you see me at the gym, maybe I'm doing a plank. What am I doing instead of just staring at the floor? Is I'm doing a no-no gaze stabilization kind of exercise to activate that vestibulospinal system. And what is the number one cause of preventable death in the elderly? Falls. Well, one of your integral parts of rehab for fall prevention is, can they keep their eyes locked on a target and move around that target? That vestibular ocular reflex is paramount. All of you should be doing this as part of your training and your patient training, whether it's for back pain or just fall prevention, balance, things like that. It's all in that brainstem switchboard, okay? I like to stack that with isometrics. So now put a band around your legs and do a glute isometric while you do a no-no gaze stabilization exercise. That is one of your most powerful postural stabilizing pathways you can drive. Way to do it. And can you imagine me at the gym? So here I am on the elliptical or something, do high intensity interval training, wham, 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 just going nuts. And then I'm down on the ground doing a plank. People just think I'm crazy at the gym. And then they come up and ask me, I explain the neurology. And now what do I see them all doing the next time? Yeah, that could, okay. So just the little things that you guys can all do as part of your own practice or in that. I was activating the cerebellum, especially her right cerebellum. So while I'm lasering the cerebellum, what would be a good cerebellar type exercise? Some sort of complex movement. This is why we like Tai Chi and yoga and these things. How about a counter phase movement? You want to see how your cerebellum's doing? Do that kind of thing. Okay? And then activate it at the same time. Like I said, you always want to stack to drive those brain pathways while you upregulate it, give it the juice, so to speak. We did vagal nerve stimulation, as I mentioned, tragus clip, laser here, massage the gut, Hulis, Resimax. We use all these devices for that brain-gut axis. How about mirror therapies? Has anyone ever worked with that? Back there, we have a mirror to look pretty. So I thought it was for me for the mirror therapies. I picked it up. But you actually cover the bad limb with a mirror. And the patient looks into the mirror and they see the reflection, but it's actually the good limb. So the brain goes, oh, wait a minute, that's moving right again, or that doesn't hurt anymore. Like we use it in complex regional pain syndromes, phantom limb syndromes, things like that. So we use mirror therapies as well. So we did that with her because she was getting like the dystonias, the trigger fingers, all that stuff. I mentioned the gaze stabilization, and we would typically mostly lasering her frontal and cerebellar pathways, okay? We throw a lot at our patients, neurofeedback, hyperbaric, things like that. I did a 1.3 ATA concentrator, and then we'd also do concentrators, or hyperbaric oxygen, and we also do concentrators. Make note of things like binaural beats, okay? The brain loves a 40 hertz frequency. Look at the studies out of MIT and Harvard and what, they're just flashing visually evoked potentials at 40 hertz, reversing amyloid, reversing tau, improving lymphatic clearance, like taking out the garbage, things like that. Another really good thing that I hope most of you in this room are doing, but I should mention it if you're not, one of your best ways to take out damaged cells and mitochondria, that autophagy and mitophagy, is your fasting, right? I do a 1-day water fast about once a month. You do have to be careful though. I think Dr. Hyman will mention this too, is that I am not as big of a proponent of the 16-8 rule of eating. Okay, I like it more of like a 12-12 kind of thing. And I'm in alignment. I believe Dr. Hyman says the same thing, is that you do not want to have muscle wasting. Okay, and what's the big drug of choice right now for weight loss? Oh my goodness, Ozempic and Trizempic and those kind of things, your GLP-1 agonists. And one of the biggest, they just did a study last week showing the bone density loss now, but also the sarcopenia. So if you're going to be on Ozempic, I know you guys know this, but your if you're on a GLP-1, they should be on something like HMB, beta hydroxymethylbutyrate, right, to prevent that lean muscle mass wasting. One of your indicators of if you're a dementia risk is grip strength. Okay, lean muscle mass, that's our only constant that keeps our brain alive, is gravity pulling on our muscle spindles. I just had a meeting with the head of space, doing the stuff for the astronauts as far as their cortical atrophy. So as these astronauts are up in space for a couple months, they're coming back, even though they're in centripetal forces, they're exercising, getting pulled down all day long, things like that. They are having some upwards of 20+% cortical atrophy. Okay, you need gravity, you need to move, that's your tonic discharge. It's our only physical constant. We need gravity. So another reason why exercise is so important. Okay, so coming back to 40 hertz, has anyone heard of binaural beats in here? They're free apps you can get. You can put the headset on and have them listen to a 40 hertz frequency binaural beat while you laser at 40 hertz. Another stacking thing, do visual evoked potentials at 40, whatever stacking you can do to increase the likelihood of summation. 10 hertz, that's your peak alpha frequency. Your resting brain state wants to be at 10 hertz, like how your brain idles like a Ferrari engine, that should be at 10 hertz frequency. Parasympathetic, I mentioned, 10 hertz frequency. subcortical integration, 10 hertz. So if you just said, doc, I want 2 frequencies only that I'm going to program into all my lasers and do with binaural and stuff, I would just simply tell you 10 hertz and 40 hertz. Okay. There's plenty of other frequencies. I even like solfeggio frequencies and Tesla stuff and all that stuff. But this, for the sake of this, just simplifying it to 2, I'm going to use 40 and 10. Okay. Obviously, again, using our functional medicine, we went after the viral loads like the andrographolides, the silver hydrosols, the biocines, laurocines, obviously CoQ10 and Parkinson's is well known. I'm wanting all of you to be doing at least 3 grams of omega-3s a day for dementia prevention and things like that. But I did a hemp combo, so she had that cannabinoid entourage effect as well as high DHA, autoimmune or an immune neutral diet, gut microbiome. Obviously, passive immunoglobulin therapies, again, probably Dr. O'Brien, people like that will touch on that this week. So I also will mention, I put on a good nootropic multi. I love the product I use has like NAC and resveratrol, bacopa monnieri in it for synaptogenesis, things like that, as well as all the albion trax minerals and all that good stuff. But why would I put on Mucuna, especially prior to rehab? Does anyone know? Yeah, it's a dopamine agonist, exactly. So if I'm doing dopamine-based therapies, like in autoimmune dopamine situations, instead of using levodopa carbidopa, I'll put them on Mucuna pruriens prior to doing the rehab, exercises, brain-based stuff, hand-eye stuff, things like that. Her home therapies included upper and lower body ergometer. I had her borrow the Wii Fit from her grandkids and she never gave it back. Her UPDRS score now is 20, last time we checked. And even her working memory, that frontal cerebellar stuff has improved. She can recall names, directions, all that stuff again. Although she isn't back at the symphony, she's back to playing cello. She has a bowel movement completely unassisted. She can perform all activities of daily living, such as buttoning her dress, feeding herself, all those things. And she even got back on the pickleball court. How cool is that? Okay. Now, she quit because we had the hottest summer ever on record in Arizona. We had over 100 days over 100 degrees Celsius. But I love it. I left Canada for a reason. I know a lot of you do cold plunges for the brain benefits. I'd rather die of dementia than get in a cold plunge again. I'm going to tell you that right now. And because, the cold water. I mean, I did my dry suit certification for scuba. I'm like, I never want to use this thing. Okay. But she still plays Wii Fit tennis and that kind of thing in the comfort of her own home in the AC. So, did I cure her Parkinson's? Absolutely not. Okay. The only thing I can cure is a ham, right? And I will say this, those that know me well know that bacon is the best brain food on the planet. I'm doing a pilot study right now. I'm seeing if I can die from a bacon overdose. It's a small study, it's an N of 1, but I'm if anyone wants to join me, let me know. But no. But here's the thing, is that some of us live like the cleanest lifestyles, and God bless you for it. I mean, you guys you're not putting anything in your body. I'm a little bit more, I have some red wine last night, that kind of stuff. I want to see, I'm a good litmus test because I want to see what else I can do to neutralize the damage. And I'm not saying, advocating wine or anything. I'm just saying I'm a good case study because a lot of our patients, we know they're not going to be eating as clean and doing all the things that we ask of them. And so we have to give them defense mechanisms. What can they do to undo the damage kind of thing? So I love the nutrients, but laser is going to be a big part of that. Okay. My favorite picture. I always laser my brain to get ready to get on stage, and somebody brought me over a plate of bacon. So here it is right there. That's my bliss right there. So I will say this, is that taking an integrative approach and stacking therapies, obviously a lot of you are doing that already, but adding this into your practice is something that I would highly, highly consider if you're not doing it already. There's a saying in the industry that says, you don't buy lasers for your practice, you buy it for your own brain and your kids, and you let the patients be a benefactor of your investment, okay? The QR code I put up there is to my office. Okay. The website is Arizona ACNC, Arizona Chiropractic Neurology Center.com. Arizona Chiropractic, ACNC.com. See, I was worried. I thought that was going to take you to like room service or something like that. And okay. Because I will say this, I kept my slides clean, obviously. There's only 2 lasers that I will put on the brains. There's one in particular that has the most research. There's 26 FDA clearances on low-level laser right now. Erchonia, write that down, ERCHONIA, has 22 of the 26. That's the one I let on my brain, on your brains, on the brains of my daughters. Zirconia. There's one other 3B that has a home version you can dose down, okay? Reach out to me because I asked, by the way, thank God we're here. I was supposed to do the Zirconia corporate event in Asheville, North Carolina. I just got a text from Dr. Brandon Brock, who most of you know. He's teaching over there this weekend. He's teaching in the dark under candlelight because of the hurricane storm that moved in. Yeah. So we're very fortunate, and hopefully everyone's safe over there, but we're very fortunate to be here. So I asked Zirconia, though, they knew I was coming here, obviously, and I said, hey, can I get you guys some sort of seminar discount kind of thing? For don't pay retail. I will touch base with me, go to my office website and stuff. I'll make sure you guys get some sort of discount on any of the laser stuff. Or if you guys have other questions about our practice, what we do, things like that. I know we have a panel tonight. I'm on, at the end of the night, we're going to get on for any questions. But because I have a few minutes left over, I wanted to take on any specific questions you might have for me right now. I'd have to know the parameters of them. So do you know what the power and all that stuff is? Okay, so as long as it's in that, I don't know all the laser parameters of all the different companies, because there's literally hundreds of them. When I said Zirconia is 17.5 and 7.5 milliwatts, you got to make sure you're that. The 3B that you can dose down, that I'm talking about, the Avant, you can dose down to 200 milliwatts for the home one. So it's not about the power, okay? And the whole depth of penetration rhetoric. There's only one thing in life that depth of penetration is important, and it's not lasers, okay? Sorry, see how many you got. Hearing loss. Ooh, okay. I will say there's direct evidence on tinnitus or tinnitus. What do you guys say, tinnitus or tinnitus? Yeah. So I have had patients do audiology pre and post our treatments, and they have had improvement in that. So when I do hearing-based dysfunction, I'm going to go upstream, if you will. So I laser external auditory meatus. I do vagal stuff to help promote enos expression, blood flow, things like that. I'll do the colliculus, so the secondary relay, and then hearing, just like memory, is in the temporal lobe mostly, right? And so I will laser the temporal lobe. Now, what else might you do for hearing loss? You might stack things like olfactory therapies, because aromatics go into that temporal lobe. Music at the same time. So you'll see me stack things. I'll even do vestibular activation. So I would definitely consider adding that as part of a hearing pro. And there are times, folks, at the end of the day, if you're having sensorineural hearing loss and things like that, and your protein synthesis is going down, sometimes you just need hearing aids, even in tinnitus. A lot of my patients they push back on hearing aids because of that. Sometimes you need to activate that pathway, just like doing a bicep curl for the brainstem, right? So, all right, another question over here.
Hey, Dr. Berry, I have a mic so everybody can hear the questions. So whoever asked it, I'm going to put you on the
I'll
mic.
repeat. I'm sorry, bad speaker, faux pas. So the question was, how about pituitary? Okay, so the pituitary, especially from the HP axis and, dopamine, serotonin upregulation, prefrontal upregulation, things like that. You can see changes in outcome of your stimulating hormones, for example, with things like that, with TSH levels and things of that nature as well, too. I wouldn't necessarily say that, like say a pituitary adenoma, I wouldn't necessarily say, that kind of situation, but there is evidence of upregulation of that. So.
Do you have any protocol or data on POTS or dysautonomia?
Oh, I love it. POTS or dysautonomia, absolutely. Now, one of the issues with POTS is that, obviously the telltales are when you get that heart rate increase of over 30 beats per minute and they start getting sweaty and lightheaded and all these, autonomic type signs, and then you lay them back down and they get better. Okay. Who's the Olympic swimmer that we work with that has it? Katie Ledecky, one of the best, most decorated swimmers of all time, has POTS. What can an athlete get away with POTS? Why? Because what's Katie doing? Floating in a pool, going this way. She's not upright. One of the keys with POTS is that when you're doing tilt table, you have to go down below where they start to spike. They have to go below where they start to spike with their heart rate. So a lot of failure in POTS therapies is they try and rehab where they're upright doing different kinds of exercise and the patient just crashes. So what you'll see me do in a POTS is I'll take my tilt table up and stop. As their heart rate starts to spike up, what do you think I'm doing then? Is I'm doing right vagal nerve stimulation to bring down the SA node, the pacemaker of the heart, to inhibit that. This part of the brain that we were talking about also is part of your parasympathetic lower brainstem. So I'm doing gaze stabilization. I'm doing isometrics with a TheraBand, but it's all below that level. And then once they start getting plasticity, then I can start to bring them up a couple degrees and a couple degrees more and a couple degrees more. Now, for any of my advanced neuromates in here, there's otolithic stuff you can do with like Epleys and chairs where they're like upside down and stuff. That's not practical for this hour. So that tilt table thing is very important. Obviously, we're seeing a lot of POTS post-vaccine injury. Okay, that's a big one. I'm sure most of you here have heard about nattokinase we're using to help clear out that S2 spike protein. There's evidence on that, direct, scientific evidence. We're obviously NAC and all those things as well too. But that's the main thing with POTS is to know to rehab them below their threshold until they can build up that neuroplasticity, okay? Back there. You didn't know you're gonna have to do this today, did you?
Yeah.
What is your protocol for the brain? Do you do like a minute on each lobe?
I love it. Okay, protocol for the brain. With this device, with the red violet, because there's more energy, I will do 3 minutes just as a standalone. Like if you don't remember anything else, I do 3 minutes prefrontal, 3 minutes apical parietal, 3 minutes cerebellar brainstem, 2 minutes vagus here, 2 minutes over the gut. Okay. Now, if it's more of a memory-based thing, I'll add a couple minutes on the temporal lobe on each side too. Can you go longer than that with the Erconi device? Absolutely. I could be under this device for an hour and not exceed threshold, if not longer. Okay. But the 3-3-3-2-2 is a good base protocol, and I use that 10-40-10-40.
And can you do it daily?
Say that again.
Can you do it daily?
Oh, I
Every day?
laser my brain every day. Yeah. When patients come in to fly in to see me for intensives, for example, they get laser 3 times. Like they see me 3 times in a day, and then I'll do laser on every single one of those sessions. Yeah, absolutely do it daily. Yep.
Are there any side effects to the 755 nanometer wavelength that people are using on their faces?
Oh, like this? No, I'm not worried about that wavelength. It doesn't. There seems to be a donut in the research that like the 600, like 635 range and the 8 range is the sweet spot, and you don't get the same benefits of red in the 700. It's not clear why that is, but I don't have an issue with the 700 wavelength. That's part of what makes it red. My issue is with the power. So those kind of things aren't going to be a super high power, like a 40-watt diode or anything like that. So, yep.
Do you know if the laser therapy helps Meniere's?
Oh boy. So does laser therapy help Meniere's? My mom was the worst Meniere's patient I've ever had. I grew up watching her have to crawl to the bathroom for 2 weeks straight when she'd have her attacks. I can say more indirectly because of the immune regulation and things like that, because there is that autoimmune kind of component to Meniere's. But by the time I started learning all the stuff I know now, she had already had the sensorineural hearing loss, so I couldn't get that back. But with all the stuff that that integrative approach that I just talked about, she hasn't had an attack since. And that's an N of 1, but it's anecdotal. But so it's not a direct thing, but indirectly with inflammation reduction, immune regulation, blood flow, all those kind of things, it can be indirectly more beneficial. Okay.
Do you have any experience with patients who had mold exposure with symptoms of memory loss, dizziness? Have you had any patients like that? Serious patients?
With mold exposure?
Correct.
Oh, so I know the complex. Okay. Chronic inflammatory conditions? Absolutely. Well, think of it on this, again, the inflammatory cascade, right? Without getting too complex on my whole mold protocol, if you will. Yeah, I'm doing lung exposure and, all those kind of things with the laser. But if you look at a lot of the chronic inflammatory stuff and the adrenal stress, like what's one of the reasons why we take NAC? When you look at immune resolution of chronic inflammatory, it's that cysteine molecule for things like TGF beta. So we use high dose NAC, we use glutathione. We use lasers also to help with the inflammatory cascade for sure. But there is some evidence, again, in that general anti-pathogen side of things. The one thing that doesn't have the most robust evidence is Lyme. I have not had, that's a tough nut to crack, obviously, as you guys know. And again, more for indirect things with Lyme, but yes, for mold as a short answer with not getting too technical, it can be helpful for that.
Go over here.
You mentioned the benefits of some of this for Parkinson's. Have you seen any of these therapies also helpful for progressive supranuclear palsy?
Good old PSP. Pretty much anything with the, any of the Lewy body stuff, the PSP, yes. The thing is with it is that, like we were talking about backstage, is like you got to get to it early, right? The earlier you get to these things, because we're working on some pretty high profile FTD cases right now and things like that. The later stage stuff, it's that much harder to bring back. But with that said, because of that, again, that dopaminergic, the vertical eye movement and things like that, we have had success in getting people's, symptoms down. It's not just like that last patient, it's not a curative thing, but their quality of life and being able to technically reverse that. Yes, we have had some success with PSP.
You focus on the lasers, the cognitive movement exercises.
Exactly. Similar to a Parkinson's type thing with PSP. So you're doing a lot of prefrontal, midbrain stuff, like I do up the nose, for example, with that. And then when I'm doing those fast eye movements, vertical eye and head activity is very much a dopamine-based thing. Okay. So instead of doing like no nose, I'm doing things like yeses and things of that nature. But again, all that hand-eye stuff and things of that nature while we laser that prefrontal cortex. But even reflexively, if they can't, drive that saccadic eye center with the technical stuff is the superior colliculus and all that stuff. Do it reflexively. Do a vestibular movement where the eyes go up, like a head tilt and that kind of stuff. Or optokinetics you can use as well too. Okay. Anyone else? I know we're right at the end of the time here, so I'll be back on stage.
We'll allow two more.
Okay.
We have two people sitting right here.
Hey, I usually lecture for 14 hours, so this is easy for me. Yeah.
Okay, we're over here.
Oh, thank you.
Okay.
Is it safe for use in patients with a deep brain stimulator?
Yes, this one. Be very careful. I got to qualify that. I have no issues like pacemakers, titanium hips, deep brain stimulators, things like that. No issues. This is non-thermal. Okay. I was on the Bob and Brad show last week and I made a comment because this is non-thermal. What's that tattoo right here called? You said it, not me. Okay.
Tramp stamp.
That thing back there. Yeah, I got written up one time for that. I can use this right over a tattoo because it's not going to have a thermal effect, for example, just one example. But you can't use high-powered stuff on that stuff. You're going to burn the patient, things like that. But you can use a class 2 low level on. I have no issues with any of the stuff, implant-wise or otherwise. So great question.
Can you talk for 1 minute about the why? Like why lasering the brain lowers inflammation?
For 1 minute?
Make it quick.
I was going to say, I know we got a break. Can I talk to you on the side about that? Because, yeah. But I mean, when you look at all the inflammatory, I'll show you all the research on lasers and inflammation. Okay. But there's stuff to do with reactive oxygen species, and there's, it's a pretty in-depth conversation. So no, I couldn't do that in a minute. But I'll find you on one of the breaks and I'll show you all the stuff on it. All right. Good. All right. You guys, thank you all very much. I'll see you all this weekend. Appreciate you. I'm looking forward to it. You guys have been